Welcome, everybody. I'm very happy to present today. Thank you for the invitations. And I would like to present the physiotherapy assessment and a little bit about scoliosis-specific physiotherapy. Let me introduce myself. My name is Andrea Lebel. I'm a physiotherapist in Ottawa, Canada. I work at the Scoliosis Physiotherapy and Posture Center, and as well as lead the Scoliosis Physiotherapy Institute in Ottawa. About my journey with scoliosis, I was diagnosed with scoliosis and going through non-surgical conservative treatment in Europe. I learned a lot about scoliosis at that time, and I feel I have a better understanding what the patients and families are going through when they're diagnosed and treated and joining the scoliosis journey. First, I certified in a short physiotherapy in Germany in 2008, and since then I'm treating scoliosis patients exclusively in a clinic and online. And my research now focuses on scoliosis and spinal disorders. My education and awareness campaign continues since 2008. Locally, we organize courses as well as awareness programs like a Scoliosis Awareness Walk each year to promote scoliosis screening and support the local hospital scoliosis awareness and treatment programs, as well as I treat patients locally and as well as online. Education I provide as well locally and internationally and online. And I do my clinical research in my small little clinic, and I share as much information and research as I can. And I would like to invite you all to also try to document your cases and raise awareness locally and provide scoliosis support programs for your patients. My scoliosis education pathway and taken many courses, including the SHROD, BSPTS, CS, and Leo method courses of PSSCs, and many other courses related to orthopedics. These are my publications and presentations. Most of the resources I collect and learn from the Scoliosis Research Society or from the International Society on Scoliosis and Orthopedic and Rehabilitation Treatment, or the International Research Society of Spinal Deformities. These are the sources which I recommend you also go to. And I can also recommend to visit the SSR library, where many presentations are available online. My scoliosis specific training and certification for physiotherapists led to become an instructor and teacher. And at first, I was approached by Crystal Schroth in 2013, who invited me to teach her method. She asked me to take part of her 95 question exam, which she prepared for teachers. We worked on several case studies together, and she placed some of them in her museum in Bad Zobenheim. After I have written the exam, I also have gained the written permission from Crystal Schroth to allow me to use her drawings and her material to teach. I'm very privileged that I was able to learn directly from her, and she asked me to teach and share her and her mother's Katarina Schroth's method. My goal is to preserve the legacy of these two wonderful, incredible women and to pass it on to the next generation, as Crystal Schroth wished and asked me to do so. I was very fortunate to spend time with Crystal Schroth and visited her many times before her passing in 2015. She will be greatly missed. In 2017, Dr. Emmanuel Rigo invited me to BSPTS to teach courses as well. After many years of learning from him and treating many cases together, I was teaching until 2020 for physiotherapists under the BSPTS school. With the online teaching becoming very busy during the COVID times, I had to make a choice and continue teaching with SSOL. Since 2020, I'm working with Dr. Jean-Claude Demarroy to bring the Leon method online. I'm supporting the physiotherapists during their practical sessions of the course. With my local courses and international courses, I always make a point that the physiotherapist is part of the treatment team, along with the physicians and orthotists and patients and their family, and sometimes the psychologist if needed. PSSC is not offered instead, or it is not taking the place of bracing or surgery where indicated. Indications for treatment are based on medical criteria and a goal of the patient-based and local, regional, and international SOSORT SRS guidelines. Education on PSSC goals and treatment plans are presented to the patients and the families before obtaining educated consent to treatment. Treatment team is providing patient-centered treatment and following the patient until discharge. Continuing education is ongoing based on new research and evidence integrated into the practice and patient care. Scoliosis education is ongoing. The incredible amount of research and publications surfacing every day is hard to follow. And with my co-founder, Dr. Hagit Berdyshevsky, and myself, we opened the SSOL Scoliosis and Spine Online Learning in 2018, where many presenters are invited and presenting current evidence. You're welcome to join. Our mission is to reach and teach and provide up-to-date information as we're growing every day. And now we are teaching on 6 continents and 91 countries. You can join the website and the webinars. You can take courses and choose your learning path, no matter the background. This is our video library, which is open 24/7. You can visit anytime from anywhere and select presentations, courses, which will suit your continuing education, webinars available for you, whether you're an orthotist, physiotherapist, surgeon, or medical doctor, or anyone else treating or supporting scoliosis patients. A little bit about SOSORT and SRS guidelines and the organizations. This is the Scoliosis Research Society guideline. So it's important that we follow international local guidelines. I myself joined the SOSORT in 2008. And since then, I managed to go to every single annual meetings and learn a lot from experts. This organization, founded in 2004, the international multidisciplinary organization promoting early intervention, conservative management through their annual meetings and courses. And I encourage everybody to become a member and follow the SOSORT organization on social media. Our current journal is the European Spine Journal. SOSORT created guidelines, treatment guidelines, which is free for you to access. This guideline gives you information to treatment by age, by bone maturity, based on the Reser sign, as well as the Cobb angle. It represents minimum and maximum treatment, and that's the range between the minimum and maximum treatment where you can find the evidence-based treatment plan for your patients. Screen or not to screen? This is not even a question anymore. Many publications have shown us that scoliosis screening is very important for early diagnosis and early treatment. Early detection of the scoliosis is critical. 1980s is when Canada discontinued the school screening programs. And this is a publication reference on the bottom for you to show that unfortunately in my country, in Canada, the late diagnosis is reaching 32%. Late referrals means that the patient is already have an advanced curve in a gray zone, reaching 45 cup degrees at the first radiographs, first x-ray. So these children are not screened on time and not identified and treated on time. This is a screening result showing in how to proceed based on the angle of trunk rotation, scoliometer measurements, and at 7 degrees is a critical point when we have to move forward in terms of the x-rays and seeing what the patient's needs are for further management of their spinal curvature based on the rotational measurement. Clinical and radiological assessment is part of the scoliosis specific physiotherapist's work, and we are spending more time with the clinical assessment as well as the radiological assessment to follow the patient, seeing progression, seeing improvement, as well as collecting many objective measures to justify and evaluate our treatment. A detailed initial assessment includes patient's history. I always ask questions to determine the onset of the scoliosis. It's very important, especially around the age 11, when the patient presents with a larger curve, to find out when the true onset of the scoliosis happened. It could determine whether the patient has a juvenile idiopathic scoliosis or an adolescent idiopathic scoliosis. And most likely the progression will be different for the two different conditions. The patient history in terms of back pain, headache, trauma, injuries, surgeries are also extremely important. Some minor surgery in very young children could indicate that the patient may have some scar tissue, some rib asymmetries, which can contribute to later develop the scoliosis. The history of the patient is also very important to ask, not just the pregnancy history, but the early childhood development. Past medical history, family scoliosis history, what kind of sports or daily activities the patient is doing is also part of the questions we ask. Sleeping patterns, sleeping positions, whether they use a night light, thinking of the melatonin production, whether they take vitamin D or what kind of diet they follow, also important to know. And any past medications, perhaps steroid use for other conditions like asthma, for example, need to be asked. We ask the patients to fill out many questionnaires depending on whether they are braced or not, and that these questionnaires are evaluated during the initial visit. Physical examination includes the growth measurements of the patient's height and weight and head circumference depending on the age. We try to establish a BMI measurement as well, arm span, tenor staging, skin examination for pigmentation, as well as some skin dimples would be very important to see. Also the laxity of the skin, any kind of lipomas or hair tuft would be documented. Length discrepancy, we're checking as well, and the angle of trunk rotation, sagittal measurement based on also plumb line posture asymmetry will be checked with each patient. Lung function and chest expansion is also very carefully examined, and range of motion and movement pattern of other joints and abilities. Of course, we will do our orthopedic physio assessment, including lower extremity, upper extremity, mobility and strength, as well as the trunk and pelvis detailed assessment, neurological, physical examination. It is part of the red flag screening process with the scoliosis specific examination. And we go through gait, balance, reflex, motor and sensory skills, muscle tone examination, and the cranial nerves as well. We check the cardiac and respiratory exam with the oxygen saturation pulse and the spirometer. Some specific tests we perform when we see extreme laxity of the joints and the hypermobility of the patient, and the Bennington scale will give us an objective measure for that. Scoliosis specific examination is part of the scoliosis specifically trained and certified physical therapists, and based on the scoliosis deformity is vertebral segments in extension, in lordosis, which deflect and accelerate towards the same side. This three-dimensional multifactorial condition is not a simple curvature, which is just representing a lateral curvature of the spine. The condition being a three-dimensional torsional deformity and condition of the spine. During the physical examination, we check the patient, observe the patient in all four views: the head position, shoulder height, shoulder position, prominences, the thorax asymmetry, waist asymmetry, superior iliac crest, pelvic and trunk deviation from the midline, as well as the lower extremities, are very carefully observed or assessed. Then we do the special Adam forward bending test to diagnose the scoliosis. We can screen out some of the scoliotic tendencies or scoliotic postures, which are not considered structure of scoliosis. When the Adams forward bending test is negative, that indicates non-structural scoliosis. When the Adam forward bending test is positive and we see rib humps and the spinal process lines deviating to the sides, that would be a positive Adam forward bending test diagnosing the scoliosis patient. I also assess the patient in sitting and quadruped to check the angle of trunk rotation. These examinations in positions, it gives us a little bit better information whether there's a leg length discrepancy, a pelvis shift. Tight hamstring may limit the patient in forward bending, in standing. Some patients have poor balance, and some younger children might be moving a lot during the sitting or standing test, so the quadruped position is very helpful for them. I also check the patient's prone compared to standing or sitting. This angle of trunk rotation difference is indicating perhaps the elastic portion of the postural component of the scoliosis, based on the research has been done in Italy. We check the angle of trunk rotation very detailed ways. We can mark the spinal processes and the PSISs. We can mark the patient very carefully to identify the apexes as well as the transitional points during the angle of trunk rotation measurements, and perhaps an indication for the leg length discrepancy if the pelvis is not leveled. We also examine the patient of the sagittal profile or the lateral view. When we know the definition of the scoliosis creating an extension in segmental levels, it is most likely visible on the lateral view of the patient. So either you see a straightening where the scoliosis is happening, or even inverted thoracic spine, even in a flexed position. This will indicate the relative anterior spinal overgrowth happening, the structural changes are happening in the vertebra during the growth. It's very important for adults to screen out the three-dimensional listhesis as early as possible. So during the examination, when we have the angle of trunk rotation measurement, we could see the angle of trunk rotation suddenly increase and then suddenly decrease during the lumbar segments. So this will indicate that the patient has possibly a 3D listhesis. In this case, the patient has to provide a radiograph as soon as possible. We check the lateral side bending range of motion. This is part of the assessment to identify the rigidity of the flexibility of the patient. We also examine the patient in brace. So when the patient is braced during the assessment, we check the midline, we check the breathing areas, we check the patient's skin, as well as we train the patient to work with the brace. Work with the brace in terms of the postural centralization. The patient actively learn to control some of these segments. We also teach the patients how to breathe in brace. And this is a very important part of one of the first meetings with the patient, because this could be done full time during the bracing treatment. The ideal brace for us is where the rib movements in 3 dimensions are not limited in the brace. And in the juvenile cases, we also want to make sure that the openings and the areas are allowing the lung tissue development and alveolar growth, which is almost doubling at the age 4 to 6 years old juvenile cases. We need to teach them how to use the brace, how to elongate in the brace, how to breathe and hold the more corrective postures with the help of the brace. In North America, braces are removed for physical activities, and we educate the patients on that. In some other countries, though, the protocol is different. So depending on where you view in this presentation from, the local guidelines will apply. Physical examination of the sagittal and posture assessment is also part of the very detailed assessment the scoliosis-specific physiotherapist performs at the first visit. We evaluate them with an inclinometer, checking the regional angles of the thoracic kyphosis as well as the lumbar lordosis. And we also evaluate them during the radiological assessments. And we make the measurements of not just the cub angles of the regional kyphosis and lordosis, but also all the scoliotic specific measurements as well. We also very detailed examination happening in the pelvic parameters and pelvic measurements, as during the physical therapy exercises, we include that information to create more precise exercises for the patients. During the radiological assessment, we check the sagittal deformity and identify the mismatches when the thoracic kyphosis and the lumbar lordosis curvatures are not harmonious and most likely resulting in mismatch with the pelvic incident. We also check the in-brace x-rays. In-brace x-rays will show us some percentage of in-brace correction. Radiological assessment will include for us to check the bone maturity, either based on the Risser or Saunders sign. And I also like to check the rib vertebra angle difference, especially for the younger patients. Know that 20 degrees and more indicates a progressive curve. Less than 10 degrees are more of the stable curves. If the lateral x-ray is available, then I also check the rib, double rib contour sign, and you can identify and calculate the rib index. This is one of the SOSOT posters I presented in 2014, showing the patient's rib index and the many segments, and showing the progression, showing the increase of the rib hump and the decrease of the rib hump during the scoliosis-specific physiotherapy treatments. Often we ask the patient what other examinations they had. Sometimes they had bone scans or MRIs, and they can all confirm scoliosis, as well as the 3-dimensional listhesis, which we have to look out for the adult progression of the adult onset scoliosis. Why do we treat AIS? What we want to obtain and what we want to avoid for our patients. Why do we treat the adolescents' idiopathic scoliosis? and it based on a consensus paper of so sort, education on the condition and the active daily living. So this is the part of what we want to avoid for our patients and what we want to teach to our patients. So we can educate the patient on active daily living postures, sleeping positions, activities, and general exercise postures to decrease the asymmetric loading of the spine. Since the patients are sitting a lot these days, even more and more hours spent in sitting, to decrease the asymmetric loading and halting the vicious cycle, which is presented by Ian Stokes, it's a critical component of the education. This is an original picture from Crystal Leonard Schrott's publication. And during the sitting position, the severe right thoracic left lumbar curvature patient is able to open the concavities by placing the arm on the chair's seat. Also check how the patients carry their bags, what kind of purses or bags they carry, and assess how to decrease the load, asymmetric loading. What is the best way to carry the bag for this particular patient? During daily activities, patients spend many hours in certain positions, whether they're practicing a musical instrument or doing some artwork. So it's important that we check how they play on a cello, how they play on a guitar, how they can manage their best possible postural corrections. We also check and the guitar player is keeping as much lumbar lordosis as his ability, and sitting up with the more even shoulders with minimum effort, and managing that posture during the practice period. We teach the patients the correct standing postures in front of a mirror. Patients' education, especially for the standing postures in adulthood, is extremely important. De novo scoliosis patients, even with the small angles of scoliosis development in terms of the Cobb angle, they're already deviating from the midline. And we know that more than 4 centimeters from the centrosacral line deviation will increase the speed of the progression of these patients. We also cover sleeping position, advising the patients how to sleep. For adolescent idiopathic scoliosis, a right thoracic major curve, sleeping on the right side is not beneficial. So for this major thoracic curve patient, I suggest to sleep on the thoracic concavity. Sleeping position for a major lumbar curvature, and will advise her to sleep on the lumbar concave side. Modification of general exercises to decrease the loading on the curvatures and do no harm is part of what we teach the patients what to do and what not to do. This is a slide from Crystal Leonard Schrott publication and book, showing what she found not beneficial for the patients to do. Because we know about the relative anterior spinal overgrowth and how does it affect structurally of the scoliosis development, we try to avoid of more extension exercises for our patients. This is one of my patients who allowed me to share her photos. She's a soccer goalie with double major curvature, and doing the training exercises of planks exercises, what she does on the field with the team. So this patient side plank was fixed in a better position, better alignment for both curvatures, as well as the plank was encouraged with the normal sagittal profile during the training period. So let's go a little bit more into the scoliosis specifics trainings and exercises. When I was at the SOSORT Lyon conference in 2009, I met Dr. Boachi, who was at the time the SRS president, saying that out of 10 patients coming to his office, he only wants to do surgery on one, and the other 9 he will refer to scoliosis-specific physiotherapy and bracing. The scoliosis-specific physiotherapy exercises are also getting more and more recognition, thanks to some of the surgeons who were speaking out and speaking up and supporting initially the PSSC methods. Work together with the surgeons and orthotists as a treating team. And when we work together, we can make a difference. PSSC and bracing is now more and more recognized by many other societies. They're saying that the likelihood of the curve progression requiring surgical treatment more decreasing with the bracing and the scoliosis-specific exercises. And what are the key components and the standard features in rehabilitation by physiotherapeutic scoliosis-specific exercises, PSSCs? What are the common features of all different methods? Is part of the consensus paper and from 2005, all methods offering auto correction in 3 dimensions, stabilization, theoretical information to the patient, so education of the patient, active daily living education and training for the patient, and restoration of the sagittal alignment. So these are 5 very important key points, which is common in all PSSCs. To have a comprehensive review of 7 major schools, Dr. Hagit Berdishevsky and Dr. Victoria Lebel together a wonderful paper of how each school is treating the patients with scoliosis-specific exercises. And all these methods are explained in this publication, and it's free access from the Scoliosis and Spinal Disorder Journal. So you're welcome to access. So indication for scoliosis-specific exercises, which I follow here, based on international and local guidelines. This is the list which I use. When surgery or bracing is not indicated, the patients can start scoliosis-specific physiotherapy during bracing treatment, while on waiting list for surgery as a prehabilitation, in preparation for surgery or bracing treatment. We also offer specific exercises before and after surgery in some cases, coronal and sagittal conditions and imbalances, adult patients when indicated, young patients, young children, modified scoliosis-specific physiotherapy, and seniors will also receive modified individualized scoliosis-specific physiotherapy. In some cases, neuromuscular scoliosis patients also benefit from scoliosis-specific physiotherapy. This is one of the cerebral palsy patients who was part of the SOSUR poster in 2016. Rehabilitation is targeting to interrupt the vicious cycle by changing the asymmetric loading. So I just wanted to show you how some of the patients before even braced start scoliosis-specific exercises and counteract the vicious cycle with PSSC. These are 2 of my patients who have started PSSC during the observation period. And the first X-ray showing curvatures not reaching exactly 25 degrees. So the bracing treatment was not initiated at these conditions yet. Patients engaged in scoliosis-specific physiotherapy based on Schrott, Leon, and based on the patient's ability, age, and compliance. So these patients have done home visits as well as clinic visits. And I wanted to point out this control X-ray in 6 months. Here, the first case was quite straight. No more scoliosis was indicated since the cup degree was less than 10 degrees. And in a second case, there is still scoliosis, but it's very interesting finding at the initial visit here, because you can see the complete wedging of the disc here, as well as when the physiotherapy exercises were beneficial, showing the disc wedging disappearing at the control X-ray 6 months later. So the patient not just improved her scoliotic curvature, but also decreased the asymmetric loading on the disc at the level of T10, 11. So let me present a few words about the Lyon method and the art brace. Since it is one of the oldest methods of PSSE, it has a lot to offer, a lot of learning, a lot of experience, and a lot of information and education coming towards us from the Lyon method. 12 portals, which included into the Lyon method education of the scoliosis specifically trained physiotherapist. I also find the art brace very interesting concepts. The physiotherapist is involved in the patient's positioning of the 3 scan. So these scans are done, the first scan is done in axial self-elongation, which in my opinion, the patient is going to learn during the PSSE training and can perform during the scan. The second scan, again, we teach that for the patients, how to do lumbar shift, normalization of the pelvis and the lumbar spine, as well as the lordosis angle could be carefully taught and positioned for the scanning. And for the last scan, the thoracic shift and the thoracic kyphosis is positioned on the patient. This is a sample of the embrace correction and the art brace for teenagers and younger patients. And this is an art brace used for adult patients. I find adults, some cases, not gonna go through the surgery. So what else can we offer them other than scoliosis-specific physiotherapy and bracing, as well as some of the very flexible curvatures, which could be completely reversed to the opposite side. I also find that Lyon method discussing the bone density and maturity and growth in a very detailed way. Vitamin D, calcium-rich diet, activities, walking, jogging, all part of the building the bone mass process. And I find the Lyon method pays a great attention to that. Scoliosis is a 3-dimensional condition, and for adulthood, prevention is key. So this patient of mine had quite a straight X-ray 2 years ago, and now she has a very scoliotic X-ray with degeneration, with listhesis, and with these problems. So prevention is key, and this is a wonderful video to see what's happening with adult patients. 3-dimensional is rotational condition for adults. It would be very ideal for us if we can reverse this process by active self-elongation, by supporting lumbar lordosis, and by derotational exercises. And I also wanted to show you this very important message from Jean Dubusset on a transversal plane deformity on the rotational aspect of the scoliosis, because we use this aspect during scoliosis-specific physiotherapy. In this video, he's showing an active brace, and he's explaining how the patient is facilitated by the pads, more of a pulling motion as a pushing motion from the pads. And he also showing that the thoracic kyphotization is happening during these transversal extensions and derotational aspect of the scoliotic pads. I use this concept during the scoliosis-specific rehabilitation. During the Schroth method, we have rotational pads at the convexities. And I also use a suction treatment similarly to the brace we've seen for the concavities, opening the concavities with more severe scoliotic patients, give the patient experience in terms of the opening of the concavity so they can do it during the exercise in a much better way. A little bit of information on the Schroth method physiotherapy. The method was founded by Katharina Schroth in 1921 in Germany and enhanced by her daughter, Christa Leonard Schroth. The Schroth method was based on orthopedic breathing. The asymmetric breathing function was recorded with the X-ray video by Christa Leonard Schroth and Katharina Schroth. Schroth method physiotherapy was practiced in the fresh air, outdoors, and gained more and more attention later on when Christa and Katharina Leonard Schroth worked with many patients coming to them and later established a clinic in Bad Zobenheim. Christa Leonard Schroth published all the education in a three-dimensional treatment for scoliosis. This book, once got translated in 2007 in English, really opened up the mind of the on treatment in North America. The block system, which they introduced, is brilliantly representing the three-dimensional aspect of the scoliosis pattern. Schroth method works with elongating and derotating the spine. The Schroth exercises are customized for the individual's unique spinal deformation. The method is teaching how to correct the breathing pattern in a rotational way, increase the lung capacity with the rotational breathing technique, helps to restore the normal spinal position and pelvis correction, breathing technique and stabilization of isometric contractions. The Schroth method encouraging the posture to be maintained not just during the exercises and the therapy, but everyday activity and life. So the 3 steps we follow is the pelvis corrections and the spinal elongation with the rotational breathing and tensing the muscles in the isometrically around the prominences. With the right thoracic curve, we have a convexity is fixed in inhalation and a concavity is always in exhalation. Muscle imbalances are also present, and these muscle imbalances are going to be addressed during the scoliosis-specific physiotherapy. Therapeutic exercises based on the Schroth method is going to be completely incorporating all the aspect of the 3D correction, the axial elongation, the sagittal correction, the deflection, the rotation, with the correction of breathing. Stabilization in that position has been documented by Christa and Katharina Leonard Schroth with an X-ray findings of the patients. During the Schroth method, the curvature is decreasing. Since then, we have the University of Alberta study as well, showing exercises and the cub angle decreased during the exercises by ultrasound examination. A few words on the sagittal deformities of the spine. This is another case, not just have the hyperkyphotic problem, but also have a slight scoliotic problem, and both were addressed during the physiotherapy sessions, and no brace were used with all these cases. A little bit of how to re-educate the sagittal profile, of course, based on the pelvic incident measurement for each individual. And some of the scoliosis-specific exercises are very helpful even after surgery. This case was presented at the SRS conference in 2017. This is one of my juvenile idiopathic scoliotic patient diagnosed at age 2. The evidence-based treatment from age 2 to 4 was to start metacasting to halt the progression. After metacasting, the bracing was implemented, and now this boy is 7 years old. We managed to do all the exercises during the casting as well as during the bracing. This is the juvenile idiopathic scoliosis case diagnosed at age 4. Braced for over 10 years. This case was presented at the SOSOR 2013. the first 4 years of the treatment by PSSE as well as bracing. I chose this other patient who had bracing treatment with Dr. Manuel Rigo, very compliant with not just bracing, but PSSE and home exercises, and reshaped the torso as well as not just halted the progression of her 86 cup degree curvature, but reduced it to 45. Patient was treated by Dr. Manuel Rigo at age 11, diagnosed already by 46 cup degrees. This is possibly a juvenile idiopathic scoliosis case if the patient is already so advanced. In a very compliant patient with the bracing as well as shrug physiotherapy, not just decreased the cup angle and the angle of trunk rotation, but also met aesthetic goals. Early intervention for middle-aged adults with scoliosis may be preferable to treating advanced deformity in the same person once he or she has become elderly. So this is based on Dr. Schwab's publication, and we do treat many adults to prevent further progression into older age, to improve future quality of life, but to decrease and eliminate pain, prevention of progression, prevention of disability. Aesthetics is usually not the primary concern, but avoiding surgery is. This is one of my case, also has been published in the Scoliosis and Spinal Disorder Journal, when a patient of a 70 cup degree, a young adult, was doing PSSE based on a shrug method and decreased the curvature to 58 cup degrees. And we have more publications showing not just halting some of the adult curvatures, but also improving some of the cup angles. And the prevalence rate is 35.5 degree, much higher than the adolescent population. And as we go up to seniors, the prevalence rate even higher than 60%. We also, as I mentioned, use physiotherapy with post-surgical cases, not just VBT and APAFIX surgeries, but also spinal fusion surgeries. And these are post-surgical scoliosis patient here with not as ideal aesthetic appearance after fusion, as well as a progressive lumbar curve. She did the shrug-based physiotherapy, improved herself aesthetically, halted the lumbar curvature, improved it by 10 degrees as well. So she was avoiding the revision surgery. This is one of my patients who's demonstrating the shrug walk, and she's going to start with her scoliotic posture. Then we're going to put the feet hip-width apart as we get ready for active self-elongation with the pelvis stabilization in the center. Once the patient is facilitated even more with the pose and going up on the tippy toes, aligning the trunk, head, shoulders, postures, and the breathing, opening of the concavities, the patient will be able to stabilize this posture during the dynamic work, the physiotherapist assisting as needed and instructing the patient to do the changes in a posture. But the compensations do happen, like here, the head position, and maintaining the best possible posture. The patient is going to engage in the next step. Once the patient is able to stabilize her posture during exercises, we hope that the patient will be integrating these postures into everyday life. We use very many PSSE methods in combination at the clinic based on the patient's ability, the patient's motivation, attention span, and I find the combination of methods very useful, especially the Leo method, which is targeting the exopyramidal system and balance education for the corrected posture. In this case, the patient is wearing a brace to manage the corrected posture, as well as doing the rock-aboard exercises, which she finds very challenging. We take all the braces off before the group sessions, So you can see that the patients here doing physiotherapy, specific exercises without bracing. We also motivate all the patients to do a variety of sports activities and stay active. And we also support the patients at our clinic. We not just encourage them to use apps to track the bracing time and exercise time, but also have them access to support programs through Scoliosis and Higgy Bears and local scoliosis awareness walks. Our most popular program is Brace Your Parent. So these are parents who come in and brace, the children are bracing them, and they feel very emotional at the time to know what their children are going through. We also have scoliosis awareness walks each year locally here, and not since COVID, but we support the local hospitals and the funding of scoliosis awareness programs and scoliosis research and treatment. Our final message: scoliosis should not stop anyone from reaching his or her goal. Well, thank you for your attention, and please let me know if I can answer any of your questions.